Good evening, everyone. Welcome. On behalf of the Worcester NAACP and our partners, AdMeTech, I want to sincerely thank you all for being here today. Your presence shows a commitment to not only your own health, but to the health and well-being of our families and our communities. Even events like this are powerful because they bring us together around something that affects so many of us, yet often doesn't get talked about. Tonight we're here to focus on prostate cancer, one of the most common cancers among men. While the reality can sound alarming, there's also some very important and hopeful news. Prostate cancer is one of the most survivable cancers, and when it's detected early, and that's the key message we want everyone to leave here with, early detection saves lives. When prostate cancer is found at early stages, survival rates increase dramatically. Men often access less invasive treatments, fewer complications, and better long-term outcomes. On the other hand, when detection comes later, the journey can become much more difficult, not just physically, but emotionally and financially as well. That is why knowledge matters. That is why screening matters. And that is why conversations matter. This presentation is designed to educate both men and women because prostate cancer doesn't just affect individuals, it affects families. We will talk about who is most at risk, including disproportionately impact Black men and what proactive steps can be taken. Most importantly, we will discuss how early screening and informed decision-making can help minimize the need for more aggressive and intrusive treatments. Let's be clear, this isn't just about information, it's about empowerment. It's about making sure every person here leaves equipped to advocate for themselves or someone they love. So again, thank you for taking time to join us. Your willingness to listen, learn, and engage is a critical part of building a healthier community. I'd like to get started, but before I do, I'd like to say thank you, a special thank you to the Worcester delegation members that are here tonight, State Rep Donahue, State Rep LaBeouf, and Senator Kennedy. I want to really I want to say thank you. Thank you. We really appreciate you taking time to come here with us and support this important matter. At this time, I'd like to just turn it over to Senator Kennedy and just let her say a few words.
Well, thank you so much, Fred. And let me turn the tables right around and say thank you. Thank you to the NAACP, AdMeTech, for having these types of convenings on an annual basis. I think you nailed the importance of it for all of us. It's about education and awareness and getting people screened and diagnosed as early as possible. And for us as policymakers, to address health disparities and inequities, it's about naming those disparities and it's about understanding them. And so it's really important for us as a community to have these conversations so that we're making sure that we are addressing prostate cancer on a multitude of fronts, both on getting more men, particularly, as you mentioned, particularly Black and brown men, screened and diagnosed as early as possible, and then making sure that as policymakers, as funders, that we're doing everything we can to address it at the policy in the state level. And I know my colleagues here and those in the delegation who couldn't be with us tonight, but I know are equally focused on this, are committed to partnering with you and continuing to partner with you. And I know folks that are here aren't here to hear me speak. I know we have some amazing speakers for tonight, so I will keep it very, very brief and just say, again, thank you and the NAACP for hosting this convening tonight.
Thank you. We really appreciate all of you for being champions for prostate cancer's educational program for high-risk men. We greatly appreciate that. At this time, I'd like to introduce Dr. Idris Dahoud with Latino Health Insurance Program. They work generally with AdMeTech, and they're going to talk a little bit about prostate cancer programs, specifically with the focus on implementing the cutting-edge guidelines for screening and early detection in underserved communities. So without further ado, I'd like to welcome Dr. Idris.
So thank you very much, Fred, and thank you very much to everybody who's present tonight. Senator Kennedy, the representatives, LaBeouf and Donahue, and of course to AdMeTech for supporting our roles that we play in the community. So I'm going to share my screen and get my first slide up. So I am Idris Tahod. I'm one of the primary care physicians working for the Latino Health Insurance Program. We see patients in Worcester and Framingham, and just want to announce that we've been doing this for 20 years now. Dr. Abreu has been around that long, and LHIP has been around that long. And our goals usually are that, we reach out to the community. We are serving mostly the underserved population, insured population. And these are, and my next slide, I'll show you what we do for each of those communities in Worcester as well as in Framingham and all along Central Massachusetts. We appreciate the collaboration that we see from AdMeTech, from NAACP, and all the involved partners in this endeavor. Certainly our patients appreciate all of that stuff that we do for them as well. So just to get an idea of what we do even though our name says Latino Health Insurance Program, it's a little misleading just by the name itself, but it started off as an insurance, as a provider of healthcare, getting insurance services. But we have three main components. So we have our goal is to, of course, to improve access to medical care. And again, the underserved populations are less likely to have health insurance, are more likely to be underinsured or uninsured, and hence not seek health care in a timely fashion. And as Fred just alluded to earlier, that it is so important as far as prostate cancer is concerned, or for that matter, for any of our chronic illnesses that we take care of, be it diabetes, be it obesity, be it hypertension, breast cancer, any of the other cancers, we are better off diagnosing these very early on. And the more information we are able to spread in the community, it is better for those individual patients to come forward, get screened, and perhaps, if they're diagnosed, get treated as well. So our goal has always been to help access to medical care, or drive access to medical care for the uninsured, underinsured populations. We help them apply for health coverage at our offices. You see in the right side in the picture, one of our patient navigators who helps drive the insurance coverage for these patients on a daily basis. As we believe that early detection obviously is key in preventing some of these conditions, especially with diabetes, hypertension, and the cancers that we deal with, prostate cancer being one of them, along with colon cancer. In the picture above, you see one of our prostate cancer survivors. He comes and presents at our meetings as well. He's one of our patients. And another one shows the vaccination programs that we run in the community as well. The second thing that we focus on is improve access to food. And again, food is a huge barrier, a huge problem that we're seeing more and more now in the last few years, especially where when we go to food banks and food pantries, the lines are long. People who are working, they're working poor and unable to afford as much for their food, for their daily lives, for daily groceries, etc. And of course, things have gotten worse and worse and worse over the last few years as well. So we help them apply for SNAP benefits, previously known as food stamps, WIC vouchers for the mothers who are in that group, in that age group, and of childbearing age. Food vouchers, of course, are not only for the uninsured and underinsured as well. In addition to that, for patients who are on Mass Health or who are on federal state assistance programs, we help them with DTA vouchers or DTA providers. We also help them with learning for English as a second language. We help them with vocational programs. So we have all these teaching, Zoom or in-person teaching going on at our offices, where we have translators, people, interpreters who are able to help these patients access these services and improve their quality of life, and help them with the social determinants of health as well. The third thing we do is improve health literacy. as we know as a physician that and as a provider that health literacy is a key. If we are able to have health literacy, we are going to win that battle. We will not have misinformation will come along. We'll prevent misinformation, as we call it. And again, as we know, the last few years with all the COVID pandemic, the vaccine hesitancy that goes along with it, that has been sowed in our society. Of course, with the measles epidemic that's going on right now in the last 2 years as well, those are very key, huge keys that we try to quell, we try to help dispel at every single visit that we see in our patients in the offices to ensure that they are following up and getting the right advice and getting the right information from their physician and not from the social media platforms that they're getting information from. So we're able to help all of these conditions with chronic conditions, especially with hypertension, with diabetes, obesity management, and of course with cancers. Of course, our patients are more Hispanic than African American, since our name, of course, suggests that we have a Latino preponderance to our patients. But we see all comers that come to our office, anybody who needs insurance, anybody who needs care. There's no racial discrimination on our end, at least, but whoever seeks to come to our offices is being represented in our the patient population that we deal with. So far, now going back to the results that we have over the last 20 years, we've screened almost 3,300 men. They're educated. We've educated almost 3,300 men regarding their risk for prostate cancer and what they should do. The one thing that always comes to mind whenever we talk about prostate cancer, and whenever I go to churches that I walk out or that I present LHIP at, the first thing people worry about is, am I going to get a rectal or digital exam done? And nobody wants to get that done. But that's where we have been instrumental in informing patients that this is a simple blood test. And if you get the blood test, if you're over the age of 45, if you have a family history of prostate cancer, or if you're of African American descent or of Hispanic descent, you're very high chance that you will develop prostate cancer or may develop prostate cancer. So you're better off identifying that with a simple blood test. And we've been able to convince them to take that blood test while they're at that meeting, while they're learning about it. And of course, I have women who come up and talk to us about saying, oh, I want to send my husband, I want to send my friend or my brother or my father to come in for testing. And then they have done so, have come to our office for the blood work to be drawn. We picked up 12 patients with prostate cancer. They were all adequately treated well, and they're all surviving and doing fine. And I hear their stories all the time saying, Doc, you saved my life. Or Doc, thank God you told me to get the blood work done when I did, and now I'm feeling much better. I'm feeling better, and I'm cured. And then they're referred to the specialists, the urologists that we deal with. They're referred to the special centers that we have, either at UMass or in Boston, and they're doing much better post-therapy now. And of course, we reassure the patients who have normal blood tests. We've had a few who've had blood tests done in the past who are treated. Now they're just being followed up as well to get their follow-up numbers done. So that's as far as our whole project, our program is concerned. We are very thankful, of course, to all the support that we get from the NAACP and the AdMeTech in holding our hands, of course, in reaching out to our patients as well. A little plug on our 20-year anniversary that we are having on July 16th. Sorry, forgive me, my phone here. Okay, it's going to go away. Since we've completed 20 years, we are doing a little celebration. Of course, it calls for a celebration at 20 years. It's going to be at the Framingham Commons, and on the 16th of July, from 4 p.m. to 7 p.m. And we'd like folks present, anybody who can come in, see us, join us in our celebration. It's a fundraiser as well for our office. And anybody who can join us would be welcome to come in. So it's on the 16th of July from 4 p.m. to 7 p.m. at the Framingham Commons. And please reserve your spot by emailing us or writing to or calling us. Thank you very much for your time.
Thank you. Thank you very much, Doctor. At this time, I'd like to welcome a true champion, a true medical champion to prostate cancer. I'd like to invite Dr. Mitchell Sokoloff to present to everyone.
Thanks, Fred. Very nice words, and it's really a pleasure not only to be here for the NAACP, but also with such distinguished other people who do so much for the community. And Worcester is a very unique part of Massachusetts, central Massachusetts. It does happen to have one of the higher rates of prostate cancer, which we'll get into in a few minutes. But really, all of the outreach and all of the support from our legislature and Senate, from groups like yours, from AdMeTech and Dr. Stern, really play a role in improving the health of our community. So anyway, I am Mitchell Sokoloff. I'm the professor and chair of urology at University of Massachusetts Chan Medical School and UMass Memorial Medical Center. I have been an expert in taking care of prostate cancer for the last 30 some odd years, starting with residency, then fellowship. And I've had experiences both in the laboratory doing very basic research, really among the early innovators in some of the treatments. And then more recently, obviously running a department here and trying to really perform a lot of community outreach. I also have a unique perspective in that 2 weeks ago, I also had my own radical prostatectomy for prostate cancer. So I kind of know the field now from both a patient perspective and as someone who's treated tens of thousands of patients with the disease. So just to echo a little bit of what's been said, prostate cancer is a very common cancer. 350,000 cases every year diagnosed in the United States. And to sort of parrot what Fred said, early diagnosis is really key. We have a variety of treatments that can depend on the aggressiveness, the amount of cancer, balanced obviously by an individual person's needs. But when diagnosed early, it's very curable. Our options for treatment are more diverse at that time. We have less aggressive treatments that can work in earlier parts of the disease. And so it's really this awareness that this is a cancer. This is a cancer that affects men, especially men of color, and that we really need to identify it early to really treat it. There are certain risk factors that increase that risk. I'll talk a little bit more about the ethnicity and being of African American men. Family history, it's where I came from. First degree relatives, fathers, brothers, uncles increase the risk 2 to 4 times. Aging as we get older, certain inherited genes, other genes, lifestyle factors, diet, exercise, smoking can all play a role. But most germane today is prostate cancer in Black men. And there are some very unique considerations. It tends to be diagnosed later in the course of the disease, often due to access and other issues where people might not get that frontline preventive care or that early diagnosis. Incidence of prostate cancer can be anywhere from 2 to 5 times higher in the African American community compared to the white community. Black men are at risk for more aggressive disease. They tend to have higher blood test values at baseline, which can sometimes influence how we interpret some of the screening tests we do. They have a higher incidence in various parts of the prostate. And due to access, there does tend to be a lower rate of definitive treatment, not only access to it, but getting it done in a timely fashion. So programs like this, identifying the importance of this disease and the early education and the awareness is so crucial to treating our patients. That's something we really are proud of at UMass. One of our anchor missions is to improve the health of the local community, and we take that very seriously. And we do a lot of outreach, especially in this disease, for that very reason. Now, as was alluded to, the beginning of all of this is screening. We know that there's a risk factor if you're African American. We know there's a risk factor if you have a family history, but that doesn't tell us everything. We need to screen for it, and that is really a blood test. That PSA blood test is an incredibly powerful tool. We have lots of different ways to manipulate it. You can look at PSA change, total PSA based on different aging. But that provides really a foundation for the screening. It's a simple blood test that any lab and any primary care urologist can do. It's interesting that the digital rectal exam has really fallen out of favor in terms of the screening. And even at the Super Bowl this year, there was a commercial about no tight ends. Go ahead and get screened, but the digital exam now is much later in the process. So for men who are worried about that, don't worry about it. You're not going to get it right off the start. So that blood test really starts a cascade that we can use. We have a lot of adjunct laboratory, radiologic, pathologic studies. This is something that Dr. Stern has really been forefront of for the last 20 years, what's known as precision diagnostics. So not only identifying who might have cancer, but who has cancer that's aggressive enough to treat. And that's a crucial part of all this. So we start with that screening test. We start with that PSA. We do have all sorts of ways of evaluating it if we want to increase that knowledge of who's at a higher risk with that PSA or who might have a risk for more aggressive disease. Along the same way, there have been a lot of advances lately in artificial intelligence and using shared learning processes to even further help design who really is at risk for this of those who are screening. Once that blood test is abnormal or once this series of tests shows that there's a concern, we do a biopsy. And now I can say from having had one myself, it's not a big deal. I always used to tell patients that, but now I can actually vouch for it. It's about a 10-minute procedure. We do it in the clinic. We use a little local anesthesia, but people can come in, they can get it done, and they should be back to their normal activities within minutes. Basically, you walk out, you can go right back to your daily activities. And that study is crucial because that will tell us whether or not you have cancer, and that will tell us how aggressive the cancer is. There are various ways that we grade or score or group prostate cancers. We combine the pathologic findings, we combine that with the blood test, with what the prostate feels like during the biopsy, to give us an idea of how aggressive a cancer is. And again, there are new molecular studies, there are more involved imaging studies, which can give us a much better idea about how aggressively to treat an individual person. So once we have that diagnosis, once we have an idea of how aggressive it is, we can then sit down, and I think Fred used the shared decision making, but really sit down with the patient and their family, and this is often a group effort. We don't target just the men alone. I saw 20 patients this morning, and every single one of them brought their wives with them, some of whom we have a long-standing relationship with because we've been doing this for a while with these individual patients. But we want to give enough information where someone can say, okay, I have a cancer. How aggressive is it? How aggressive do I have to treat it? And so we sit down and we take into consideration the age, the health, the degree of cancer, potential side effects. The prostate, unfortunately, is it's located in a very precarious location in the man's pelvis. So any treatments can sometimes affect urinary function, bowel function, sexual function. Obviously, time off of work to recover from treatments, undergoing the component of testing, scheduling, and stuff. We try to take all of that in consideration so we really apply to each individual man the best treatment for their cancer and the best treatment for their circumstances. And people differ. Every single being that we see has a different thought process, a different goal. There are some who, want the most aggressive treatments for the cancers. There are others who are very concerned about sexual function, bowel function. And fortunately, we have really kind of a smorgasbord. We have a whole variety of treatments where we can really eradicate the cancer and cure it, but to that individual patient and their family's best needs. Those treatments include surgery. We do those really for the last 20 years robotically, minimally invasive surgery, small incisions, quicker recovery, less side effects. We have several forms of radiation, seed implants, which is an outpatient procedure where you're back to normal activities in a couple of days, outpatient surgical procedure, external beam, which is a daily treatment, but a very quick treatment so people can continue to work and do their normal activities. Over the past several years, and again, something that Dr. Stern has really focused her entire professional career on. We have focal therapy, where instead of having to treat the entire prostate, sometimes we can treat just a portion of it. Goes by the name right now here, we used to call it HIFU, which is an ultrasound-based focused treatment, less side effects, perhaps not quite as effective as the radical treatments, but gives excellent outcomes with a lot less side effects. There's surveillance, where we monitor patients. And again, with some of the studies we have and the ability to use different x-rays and blood tests and genetic tests, we can really help optimize someone's chance of deciding or determining when they might need intervention. But a lot of men we just sort of monitor and follow. I would say probably 60% of the men I diagnose, we don't have to treat right off the bat. But for those other 40%, without treatment, they could have really, incredible problems. You can get spread, you can get metastasis, you can get disability, you can die. So that initial diagnosis is crucial, and then deciding which one of these treatments. If someone should have metastatic disease, which fortunately is the minority of men, because we have done a better job of screening, there are, again, a whole host of newer treatments. The foundation goes back to the 1940s, believe it or not, what's known as hormonal therapy. Huggins and Hodges got the Nobel for that in they discovered it in 41. They got the Nobel for it in the 60s. But based on different types of chemotherapeutic agents, immune modulating agents, small peptides that can interfere with various pathways within the body, even someone with metastatic disease can live 5 or 10 years with a diagnosis of advanced metastatic cancer. So it's a field that's evolved in my professional career. It's a field where here in central Massachusetts, we can offer the latest and the greatest in treatments and in management strategies. But it does all start with education, awareness that this is a disease. This is a disease that primarily can affect the African American community. So if people just need to know that this is a population that needs screening, needs education, we facilitate appointments. You can come in and talk to us. We'll guide that diagnosis and management to each individual person's needs. I know Dr. Stern's going to talk about some programs where we really have targeted the African American community, something, again, she really, really, really excels at. But programs like this are so important. The work of the NAACP, of the Latino Health, with our own state legislature and Senate, it's getting people the education, the access they need so we can treat them. And I think, Fred, I'll probably leave it at that unless you want me to add anything.
No, thank you very much. We appreciate that. That was very informative. Up next, I'd like to invite someone who's no stranger to educating us when it comes to prostate cancer and doing some of the things that we need to do to keep ourselves and our loved ones alive. I met her over a decade ago, giving a presentation at NAACP, New England Area Conference. That's our state body. Giving a presentation. I didn't know anything about prostate cancer or the effects it has on black men until I heard her give her presentation. And for myself, once I heard her talk about the PSA test and how simple that is, ever since then I've been doing it every time I get a physical. I make sure I get a PSA test done. Without further ado, I'd like to introduce Dr. Fiona Stern. The floor is yours.
Thank you so much, presentator. It's great to be here with everyone. It's important for me to see our main partners in prostate cancer awareness, clinical care equity in Worcester here, including, of course, Worcester NAACP, Mitch Sokolov, who took care of so many patients who we refer to make sure that they will take advantage of incredible care and incredible kindness he offers his patients. Also, Latino Health Insurance Program, leaders of legislature, Senator Kennedy, Representative Donahue, Representative LaBeouf, thank you for showing up here. Thank you for showing up for our prostate cancer program at the State House. And it makes it possible for me to have, possible for us, all of us, to get together and pursue the kind of programs we are creating in Massachusetts. Together, we are working towards making Massachusetts the first state not only to improve prostate cancer care for everyone and save lives, but also the first state to eliminate health disparities in prostate cancer. And I'm not saying this lightly. If military medicine could do it, if veterinary if Veterans Health Administration could do it, Massachusetts with universal access can do it too. I would like to ask my staff there have been so many problems that we experienced with PowerPoint presentations over a period of time. So I would ask my staff to play the video we prepared. My name is Faina Stern. I'm a physician and founder of the AdMeTech Foundation, a nonprofit organization providing leadership for groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming prostate cancer care for everyone and reducing health disparities in Black, Hispanic, and Latino men. Dr. Sokolov described recent advances in patient care. The focus of my talk is on a prostate cancer equity resource project launched several years ago to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. AdMeTech Foundation was established in 1997 with the mission to create precise imaging of prostate cancer, critical for early detection and image-guided, minimally invasive diagnosis and treatment. We focused on prostate cancer for two main reasons. First, prostate cancer is the most common cancer in men. It is as common among men as breast cancer among women. And second, prostate cancer is a leading health disparity. Black, including Hispanic men, are 2.5 times more likely to die, even though prostate cancer is curable when detected early. Since 1997, we have been leading pioneering research that resulted in creating advanced MRI, molecular imaging, robotics for biopsy and treatment, and other precision diagnostics that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate imaging for men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, leading health disparity, and public health priority. By 2013, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a new standard in patient care for guiding biopsies and treatment. Since 2014, we expanded our efforts in public awareness, reaching countless people. Since 2016, we established annual global summit on precision diagnosis and treatment of prostate cancer, which, unlike other medical educational events, brought together leaders of all medical subspecialties involved in patient care, took down interdisciplinary silos, and became instrumental in creating a broad international consensus on the best clinical practices and research priorities. This event has been widely recognized for accelerating integration of advanced imaging with molecular, genetic, and other diagnostics for precision, individualized patient care. In 2021, we had launched Prostate Cancer Equity Resource Project to make sure all Massachusetts men had access to the best care available today. And in 2023, based on the summit recommendations, we created an international working group to expedite clinical testing and large-scale implementation of image-guided, minimally invasive treatment. Prostate Cancer Equity Resource Project is an important part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national and global leadership in public awareness, medical education and research, and clinical care equity. We are grateful to Worcester delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2009 in collaboration with multiple organizations and has 4 components: public awareness and community education, prostate cancer equity resource in clinical care, medical education, and research. Our public awareness and community outreach is focused on the most vulnerable and underserved individuals. Since January 2025, we reached over 20,000 underprivileged individuals. Since 2019, our public awareness and education program reached well over 70,000 people. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 9th annual conference took place in September last year. Over 400 physicians took part in this event from just about every corner of the globe. Our media partners published over 60 scientific presentations, reaching over 35,000 international clinicians. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. Indeed, our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. It is difficult to find any corner of the world that has not been reached by this event. Since 2021, our summit highlighted that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, in 2022, AdMeTech launched Prostate Cancer Equity Resource Project in Massachusetts in collaboration with Mass General Brigham and UMass, with the mission to save lives and deliver high-quality care for all. More recently, experts at the Beth Israel Lahey joined this effort. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts
who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their prostate health journey. This program helps men to find an expert for initial or a second opinion, in person or virtual visits. We strongly believe that our prostate cancer equity resource, integrated with our large-scale public awareness campaign, has been placing Massachusetts in a strong position to become the first state in our country to eliminate health disparities. Experts of the Prostate Cancer Equity Program can address any question about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their prostate health journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined process of patient referral and care. This process assures that every man who comes to our program is taken care of in the way our AdMeTech team and doctors would like to take care of our families and friends. I would like to provide a recent example of how Equity Resource Project has been making a difference. About 2 months ago, a state representative expressed concern about Richard, a 63-year-old Black man in his district who was recently diagnosed with prostate cancer but was unhappy with his care. Several days later, Richard contacted us. He was concerned that he was offered invasive radical surgery with all the related complications and no clear information about other possible treatment options. We referred him to one of the leading clinical experts. On March 4, Richard contacted AdMeTech to explain that a letter from his primary care physician was required prior to his visit with our doctor, but he was not sure how to obtain it. We guided him through the appropriate steps. 2 weeks later, Richard saw a PCE expert who reviewed all his clinical testing and explained all the available options. Based on this information, Richard became clear about his options. He was happy that our expert recommended active surveillance and non-invasive clinical observation instead of radical surgery. Richard expressed trust and confidence in his new medical team and chose them for the future clinical care. Emma Coyer serves as a manager of the Prostate Cancer Equity Resource Project. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech Foundation's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, Beth Israel, and other clinical partners to expedite medical visits and address any needs you may have. Together, we empower each man to make informed choices that are right for him before and after screening, biopsy, and treatment. If you have any questions about our program or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you so much for your attention. Emma, do you want to say a few words as a manager of Prostate Cancer Equity Program?
Sure. Nice to see everyone. As Dr. Stern mentioned in her presentation, my name is Emma and I'm the manager of the Prostate Cancer Equity Resource Project. So if you were to contact the project, I would be the first one that you would talk to. And I actually am a Worcester resident. I've lived here for 8 or 9 years at this point, so very passionate about this community specifically. And I think our call to action tonight is that we are here as a resource for you. If either you or any of your friends, family, community members have any types of questions, concerns, or having any problems with your care, we're definitely here as a resource, and you can feel free to reach out to us. And I spend my entire day taking care of people, making sure they get the best experience, so I'm definitely here for you. And I can just put the contact information for the program in the chat, and feel free to reach out to us, and we're here for you. Thank you.
Thank you so much, Emma. President Taylor, all of us, Dr. Dahoud, Dr. Sokolov, and I will be happy to answer any questions.
Before we start, I want to recognize Vice Chair of the Worcester City Council, Christian King, is on the call. He joined a few minutes ago, and I just wanted to recognize him and thank him for taking time to join us this evening.
Thanks, Fred.
Does anyone have any questions? There is no such thing as a silly question, so now is a good time to learn things and be educated, because that's what these folks are here. We have professionals here that can help out. I have a question for Dr. Sokolov. I know the early detection is key with prostate cancer side of it. So how often, or what do you think is a long period of time, or how often do people come in and it's like too late? Like, what are the symptoms, or what are some things that people can look for if they have a loved one that may have symptoms that's like, hey, you got to go right now, or you're gonna have some serious problems?
I really do think that in the last 5-10 years, we have done a much better job at outreach and education, where it's pretty rare for someone to come in with, advanced disease, spread of disease. And the key to the screening that we've been talking about, the blood test, is that most cases of prostate cancer really don't have any symptoms. Prostate cancer by itself will cause symptoms if it spreads parts of the body. It's so large locally that it starts to interfere with urination, but that's pretty late in the process. There are normal urologic conditions, enlargement of the prostate, which can cause difficulty urinating, infections, which you can imagine cause fevers, chills, burning, all the kind of things. But if someone's having symptoms, it's almost too late for cure. We can treat them, obviously, and fortunately, with all the advances, we can keep people alive for a long time. But I really want to give a shout out to been doing this for the last 20, 30 years, the barbershop projects, AdMeTech. I really think we've done an amazing job within the United States to really identify populations that are at risk and to really improve that early screening. But if anyone were to have any abnormality in their urination, blood in their urine, blood in their semen, just not feeling well, see your doctor. Part of, as you said, every year you're getting a PSA blood test. You must ask for a blood test, and that's going to be the best way to find things. Hopefully that answers your question.
Thank you. Senator Kennedy?
Thank you. I want to thank everyone for the presentations here tonight. It's incredibly informative as always, and so I appreciate the reminders. I'm curious from a policy perspective, and I think you said that Dr. Sokolov, that the blood test is something that would be a standard part of blood tests that individuals that go to the doctors would be getting on an annual basis. I'm curious if there's other standard treatments, like I'm thinking of, colonoscopies, pap smears, other ways that are screening on a regular basis, regular schedule mammograms, et cetera, for other cancers. If there is other standard kind of procedures that could screen early on, and if there's barriers with insurance, or if there's others from the field, again, thinking from a policy perspective, if there's ways in which we could make those things more standard or more accessible, et cetera.
Absolutely. And in terms of, I won't say policy, but in terms of adherence, there was a huge pendulum shift back, unfortunately, back to normal about 10 or 15 years ago. PSA in the 80s really came of age in the 90s, actually, when I was a resident. And there was always a concern about overdiagnosis. And to be honest with you, at the time, not knowing as much about the biology, not having the precision diagnostics that Dr. Stern is talking about, there were a lot of men who were overtreated who nowadays probably surveillance. So national policy and certain medical groups kind of said, well, we're over screening for it. No one ever dies from prostate cancer. Let's not do anything. That fortunately has swung back again. And I can even tell you that just, UMass, we had a working group within our own electronic medical record for the primary care docs to make sure they're documenting annual blood tests and, how to basically have sort of an automatic escalation if it's abnormal and to make sure there's reminders to do it. But for prostate, really, it's going to be the blood test. Digital rectal exam has always played a role. Like I said, it's a little bit less nowadays. Colonoscopy, there's really nothing to visualize. Prostate cancer tends to be a microscopic disease. It can infiltrate prostate. MRI, which has come miles from where it was 20, 30 years ago, still isn't a definitive diagnostic. Ultrasound isn't a definitive diagnostic. We use them in combination with the biopsy to make this more accurate. But it's really, believe it or not, the blood test. And that is covered by everything. Even some of the nuances I mentioned, some of the molecular variations of it tend to be covered by most insurances. But it's really the blood test, believe it or not. It's that simple.
Thank you. So that PSA, let's see if I get it right. PSA, is that a prostate-specific antigen test? Is that what it stands for?
So that's a protein that the prostate makes normally. It's part of involved in reproduction. And then really in the 1980s, it was determined that higher levels of the PSA blood test can be associated with a higher risk of prostate cancer. So that's when it all started. And then lots of derivations, PSA based on size of the prostate change over time, things like that. But prostate-specific antigen, PSA, and like I was telling Senator Kennedy, it's available and it is covered by everybody.
Fred, we actually have a question in the chat.
Oh,
Question: if men have a family history of prostate cancer, what is the earliest stage they can start getting screened? Mitch, do you want to address that?
Absolutely. So one, anyone can get screened at any age. When I was chair of urology at University of Arizona, actually the police and fire recruits were getting screened yearly. You could see some of these of really young, very healthy 30-year-old firefighters who actually have prostate cancer. So you can always screen for it. The utility of that in a younger population is less. Really, for family history, and that's where I come from. I have a very, very strong family history. Really, 40. Some people might say 45, but if you're African American, you have that family history. Start at 40 or 45 with a blood test. I always mention that when I'm counseling a patient who has prostate cancer. Do you have any sons? How old are they? Make sure they come and see me in the next couple of years when they hit 40. But 40 is probably the easiest number to use to guide them.
Actually, our prostate cancer equity program accepts men starting at the age of 40 because unfortunately we have no evidence of benefit of prostate screening programs for men who are younger than 40 years of age.
Yeah, I always thought it was really strange that the fire police department did that.
I have a question. I have a comment to make actually regarding the prostate cancer screening process that we see, or the barriers that I see in the community. And one of the things that we see is that, of course, it's covered by most insurances, which is very good. And secondly, even if you don't have insurance, we can refer patients to, and the AdMeTech Foundation helps us out in getting these prostate cancer screening done for those patients. However, it's difficult to get those patients to come to the doctors. Some of the patients who don't have health insurance, they don't know or get prostate cancer screening for free. Then there is this whole issue that I have at least been seeing more and more of, even in the state of Massachusetts, where we have 98% insurance availability or almost universal insurance throughout the state, where the insurance companies drop certain things. So what do I mean by that? So say I don't want to single out UMass, but UMass stopped taking Tufts Public Health. And so there's a battle between one group of hospital services and one group of insurance services. And they don't want to pay for certain things. And then now they have to find all new sets of doctors. Because if they were going to Dr. Sokoloff for getting their prostate cancer care or whatever care that they were getting through UMass physicians, if they were on a particular health insurance, they cannot come to UMass anymore. Same thing happened with one of the Boston hospitals. And to make matters worse, if I add this one caveat, is if there are people who don't speak English and don't know what they can get done, then they don't seek care. They don't come to the doctor's offices, don't get the blood test done until it's too late. So this is the same high-risk population that already is at high risk because of their ethnicity, and now have poor access to care because they don't have insurance. The third thing that is a problem now, especially in the last few years, that we see is the immigration enforcement. That is keeping some of these people away from coming to the doctor's office, especially the Hispanic community. Well, they're worried that if they come in, if they seek care, or if they come to the doctor's office, they might get into trouble for anything else that they should not have gotten into trouble for. So that becomes another challenge as well. And for the delegation to hear about it is very critical. And it's hard. It's hard. The medical landscape, I think, is difficult to kind of go through for someone who speaks English, for someone who doesn't speak English, or doesn't have the resources, or doesn't know who to go to. It becomes a major challenge. And perhaps the legislative body can help us ensure that insurances cannot just drop hospitals. Hospitals cannot just have a disagreement on payment with the insurance companies, and now suddenly patients have to fend for themselves. And those are people who are really getting sick and left behind.
I mean, that's a very valid point.
Yeah, it is, yeah.
But that as a safety net hospital, I mean, it really breaks up our leadership when an insurance company and the hospital can't merge together, but it does happen. And not to go too far down the rabbit hole, but I did something yesterday that I'm hoping might be the most important thing I've ever done as a physician. And I've been started robotic stuff early on. Panel yesterday with Harvard Pilgrim, going over what they covered and not in urology. Just the very standard things. Some of these very standard molecular tests that Dr. Stern and I have talked about, they don't cover. And it's sort of like, are you guys insane? This is NCCN guidelines. These are every guideline from every organization in the world. And I'm hoping that I kind of changed their tune on covering probably a couple dozen things that they weren't covering as of yesterday morning. We'll see if that actually made a difference. I'm hoping I did. But yeah, you have a very legitimate concern there. Absolutely.
It's a real serious societal issue that even with Massachusetts universal access, they still require at least green card to qualify for Mass Health. And so people who do not have green card do not qualify, with one exception, unless men are diagnosed with prostate cancer or have any kind of related medical emergency. When men are diagnosed with prostate cancer, they will be covered by Mass Health, even if they do not have green card and they're not citizens. For citizens, it's easier. Even if somebody who, let's say, a citizen in Massachusetts, but their income is slightly higher than the kind of income required by Mass Health, and they do not have adequate insurance to get a great physician. AdMeTech is working with National Cancer Institute, and they accept any citizen for free care. But once again, it requires citizenship. There are societal problems that need to be solved with men and women and children who need care and who cannot get access right now cannot get access to healthcare. And of course, these are the kind of patients that are likely to end up in emergency room and cost much more to healthcare than preventive measures. Any other questions, President Taylor?
Any other questions, anyone?
So if I could follow up on that, just
Sure.
ask Dr. Dahoud, if you could possibly, I'll put my email in the chat. If you could send me a couple bullets on that. Admittedly, I am not an expert in healthcare financing, but we have an amazing chairperson in the Senate, and I know they do in the House as well. I'll speak for my colleagues. I'd love to share this information. I know we're constantly looking at, healthcare financing and insurance and what we can and can't do. Certainly within Mass Health, we have far greater control than with the private insurers, but we certainly have looked at different policies in the past. So I'd welcome the opportunity to follow up. I'll put my email in the chat.
Thank you very much.
I will just note we are to the other point you raised, and I couldn't agree with you more. We are taking up the PROTECT Act in the Senate tomorrow that the House passed, which is a comprehensive defense against ICE bill. I'd say immigration bill, but it's really about, and one of the key pieces of it is redefining sanctuary spaces in the state. So hopefully, and again, I know it's a terrifying time being tormented by our federal government, but hopefully reestablishing here in the Commonwealth that our healthcare facilities are sanctuary spaces. Apologize for my dog's excitement in the moment, but happy to talk more about that too.
Any other questions, comments? Well, thank you all very much. We really appreciate it. In closing, as we come to a close, on behalf of the Worcester branch of the NAACP, I want to sincerely thank you all for being here tonight. We're especially grateful for our elected officials, your presence and support, and all of the presenters who made this program meaningful. We really appreciate you. A heartfelt thank you to the AdMeTech team, Dr. Stern, Thomas Satham. We really appreciate you, what you do, sharing your knowledge, your time, and your dedication in advancing health equity and saving lives at the end of the day. That's what we're doing here. We're trying to save lives. The truth is, each of us here today leave here as an ambassador. We now carry something with us powerful, tools of knowledge about prostate cancer, about who it affects most, the importance of screening, life-saving power of early detection. We know that that's really important. With the knowledge that comes responsibility, right? We're all responsible. We must spread the word. We must have conversations. We must help eliminate stigmas around men's health. We all know about that, especially in communities where silence can truly be deadly. This doesn't end here tonight. It continues in our homes, in our communities, in our churches, in our everyday conversations, because when we speak up, when we share, and we encourage men in our lives to get screened, we are actively saving lives. Together we can make a difference, not someday, but today. Thank you all again for your time, your presence, and your commitment to the important cause. Let's continue to do this. Let's work together. Thank you.
Thank you
so much. Thank you.
Thank you very much. Have a good evening, everybody.
Thank you.